We are live now, Speaker.
Okay, thank you, Doc. 1 minute to go. Okay. Okay, we're starting now. I see Professor Rhys has joined. Thank you very much. Good evening, Prof. Good evening, Joe Burgers. Welcome to the talk with myself, the Speaker of Council, Councillor Nongceba Mulwele. We are live on various platforms, such as City of Joburg social media platforms, as well as my own page, which is Nongceba Mulwele on Facebook, and @speaker_COJ on Twitter. We are also live on Jozi FM until 7:30 p.m., following which we will then take the stream and play it on Eldos FM between 8 and 9, and on Alex FM. It will also play on Kai FM tomorrow morning. Kai FM is our newest media partner, and we are very pleased that this civic education community media team is growing, and we are very happy to have them on board. They will give us the exact time where they will play this stream tomorrow morning. Ladies and gentlemen, I cannot place more emphasis on the importance of having community on board in educating our communities on the work of government and council in particular instance. A very warm welcome to Ms. Kathy Kayla, who is the station manager at Kai FM and who is also on the platform. I hope she has tuned in. Warm greetings to Mr. Colin Hans, who is our anchor on Jozi FM. Very special greetings to all the listeners, all our viewers, our panel of experts, Professor Musa Mushabela, Professor Helen Rhys, and Dr. Nyati, who is also our civic education partner and who will also facilitate today's show together with Mr. Colin Hans. Tonight, ladies and gentlemen, we are talking about the impact of AstraZeneca vaccine on South Africans. Last week, we spoke about COVID-19 pandemic and vaccination truths and myths. We received an overwhelming response with many questions and comments on this topic, and therefore decided to do a second series of the conversation. A follow-up on the discussion became more important, especially after the announcement made by the ministry this past Sunday to halt the rollout of the AstraZeneca vaccine. I think it is safe, ladies and gentlemen, to say that this announcement was met with shock and uncertainty. The Honorable Minister Mkhize just this morning advised us that South Africa halted the planned rollout of the COVID-19 vaccine developed by AstraZeneca and Oxford University after data showed it gave minimal protection against mild infection from one variant of the virus found in the country, known as the 501 YV2 COVID-19 variant. He said that the results of these studies only became available last Friday, the 5th of February, and publicly released on Sunday, the 7th February 2021, which is where the announcement was made. The variant was identified in December and is now the dominant variant in South Africa, responsible for 80 to 90% of new infections. But what does all this mean in simple terms for the ordinary men and women on the street? I'm very excited to announce that To help us unpack all these developments, we are joined by Professor Helen Rees. Professor Helen Rees chairs the advisory committee that is advising the Minister of Health on COVID-19 vaccines and the South African variant. She is the Executive Director of Vets Reproductive Health and HIV Institute, the largest research institute at Vets University, and chairs the board of the South African Health Products Regulatory Authority. She is also a personal professor in the University of Witwatersrand's Department of Obstetrics and Gynecology, and is the co-director of ALIVE, African Leadership in Vaccinology Expertise, which is Wits University's flagship vaccinology program. Professor Rees is an expert in vaccines and will help us make sense through her analysis on the research and what exactly transpired for us to find ourselves here as a country. She will also advise on how AstraZeneca works and why it will not be effective in the South African context. All of this will be in simple language so that you and I, the man on the street, can understand and make sense of it. Welcome, Professor Rees, and thank you very much for joining us this evening. I'm also delighted to introduce Professor Musa Mushabela, who is a chief medical specialist, trained as a medical practitioner and specialized in family medicine and primary health care. He further completed a master's in demography and health and a doctor of philosophy in the field of public health. He is also the national chairperson of the Standing Committee on Health in Academy of Science of South Africa. He is the chairperson of a subcommittee to evaluate and report on the national health sector response to COVID-19 in South Africa. In the province of KwaZulu-Natal, he is appointed as a health commissioner in the Provincial Planning Commission. Professor Mushabela will assist us in responding to what happens now. Now that we know what we know, now that this vaccination rollout has been suspended, what is the impact of this suspension on citizens of South Africa? And how do we, as ordinary citizens, move past this to ensure that we do not lose focus on overcoming this killer disease? Welcome, Tate Mushabela. We are honored to have you on the platform this morning, and thank you very much for making time. A very warm welcome to both our guests. We have our resident doctor on the show, Dr. Nyati, who is a medical doctor and qualified specialist and family physician and a seasoned healthcare entrepreneur. He is the founder and CEO of Proactive Health Solutions. He is a leading healthcare industry thought leader and is our partner in civic education in the City of Johannesburg Legislature. I wish to take this opportunity to also welcome Doc on the show. Doc is going to facilitate today's show together with Mr. Colin Hans from Jozi FM, as I said earlier. I must say that because we are engaging with our communities, this engagement will take the form of a more relaxed format and less of a formal academic style approach so that we ensure that we take everybody along and leave nobody behind. By the end of this show, everybody, a man on the street, as I said, will understand even the lingo that will be spoken here. At this point, let me hand over to Doc just to give a little bit of a context. And then Doc will hand over to Mr. Colin Hans. And welcome, Doc, on stage. And welcome again to our viewers and listeners. Thank you very much. Over to you, Doc. Just 3 minutes to give context on the topic for today.
Good evening, speaker. Good evening to our esteemed guests, and also good evening to all the people who have tuned in. My name is Fundile Nyati, and I've been asked to kickstart this discussion. I think it is very clear in your introduction, speaker. you mentioned that there was an announcement on Sunday. That announcement was that the vaccines that had been received by South Africa on Monday last week, coming from India, that are part of the AstraZeneca, vaccine program, there was a problem, and that problem is such that those vaccines cannot be used up until the experts, have come up with clear ideas on how best, to make use of them, because they were found not to be, very, protective against the new variant of COVID-19. Now, I don't want to waste time. I think maybe, Speaker, I should just, Prof. Rees, to just maybe in simple language, what was that announcement all about? And then, we will then go also to Prof. Mushabela to also say, what does it mean, in terms of the broader vaccination? So maybe let's start with Prof. Rees. What was the announcement all about? What is a vaccine? What is a strain? What is a variant? Because people are using all these terms, interchangeably. And maybe if we start there.
So perhaps, yes, let me start by explaining what a vaccine is. A very good idea. First of all, thank you very much for this invitation. And I'm going to do my best as a scientist clinician to try and keep it simple. And you must stop me if I'm going over the top. So as you know, and many of you will have children and so on, and you'll know that you take your children for a whole number of vaccines. Vaccines have been around with us for many, many years, and they are probably our most powerful tool at preventing infectious diseases. They save literally millions of lives every year, and particularly children's lives. That's why we give so many childhood vaccines. So what a vaccine does is, in the case, take the case of COVID. So what we do is, when we make a vaccine, we take a piece of the virus and we make it into a vaccine. And there are different ways that we will put that vaccine together. So there are different ways that they work, but they all will have some sort of piece of that virus. And then we give it to the person. And in the body, our bodies will then recognize what's come into the body and say, aha, that is foreign. We don't like that. We don't like the look of it. And our immune systems kick in. And there are different parts of the immune system, but all of those pieces of the immune system will kick in, and they do different things. But the aim will be, first of all, to get rid of that foreign invader that's come into your body. But what it also does is it gives your body a memory. Your immune system actually has a memory and remembers what it's seen. So when the real virus comes along, the immune system says, ha, I've seen you before, even though it's just a little bit of that virus perhaps, but they say, aha, I've seen you before. And immediately the immune system goes into overdrive. It really steps up. And all of the different components of the immune system kick in. And it's a way that we can either stop the infection altogether, that's one thing a vaccine can do, or dampen down the infection so that the illness that the person gets is not as severe. So a vaccine is basically a way of tricking your immune system into recognizing an infection that you haven't had. So when you do get the infection, it can go into overdrive. So that's the first part. That's what a vaccine does.
Yes. Yes. All right. Yes. Now we can continue, Prof.
Okay. So perhaps the next thing to make sense of what's happened with AstraZeneca that I'll perhaps just talk about is just COVID infection and COVID disease. What do we know about that? Because that also makes sense about where the vaccine fits in, but also what we look at when we say, does the vaccine work or not? So if you think about COVID infection, before you've been exposed to the infection, the most important thing we want to do is prevent infection, and that's where vaccines fit in. But many of you listening might well have had COVID infection by now. And there are different there's a range of seriousness of that infection, varying from people who have no symptoms at all, they're infected but no symptoms, to those who have very mild symptoms, sometimes won't even go to a doctor for those symptoms, a headache, a cough, but they go away. And then there are those people who have more serious symptoms, and they might well go to a GP or a clinic, but they don't need to go to hospital. Their bodies will fight that infection naturally. And then at the other end, there is severe disease where people will go to hospitals. So prevention, that's the first part. We want to stop it. But if you get the disease, there's mild infection, moderate infection, and severe infection. So when we give a vaccine, we want to know, first of all, can it stop that infection happening altogether? Or does it keep the disease at a mild level or a moderate level? And can it stop severe infection and death at the other end? So when we measure how well a vaccine's doing, we look at all of those parts of that disease severity, from mild to moderate to severe. So what's happened with the AstraZeneca vaccine? Although it is an effective vaccine, it's working very well. They're rolling it out in the United Kingdom, for example, and it's working well there. Overall, we thought it had about a 70% effectiveness as a vaccine. So that was where we started. But what we now know is that our virus in South Africa has changed. Now, viruses change all the time. They change all the time. They're very clever and they adapt all the time. And many of those changes don't mean anything. But what the virus tries to do is to change in a way that's an advantage to the virus. And one of the advantages to the virus is that, I'm a virus. I want to infect you, but I also want to see that I can jump to another person. And so the virus in this case, has adapted, so it's more easily transmitted from one person to another. So that's the first thing that this variant in South Africa has done. We've also looked to say, does this variant cause more serious disease? And at the moment, we're not seeing that, but we are seeing that the virus is more easily spread from one person to another person. When we had that second wave, you're all familiar now, we've just had this huge second wave with all the measures for lockdown again. One of the reasons that was such a big wave with so many people infected and was so quick was because this virus was spreading more quickly. And that's what one of the things that the variant has done. But we also wanted to know now, do the vaccines that we developed, remember we developed those vaccines starting with the original virus from China. So all of those vaccines were designed to look at that virus that came from China. Now we've got a change in our local virus, and we've got this variant, 501YV2 we call it, but we'll call it the variant in this discussion to make it easy. So we look to see, does the vaccine is it still as effective as was shown and is being shown in the United Kingdom against the original virus? And so a number of studies are being done. There was just one small study done in South Africa. And by vaccine standards, this is a small study because you've probably heard, we usually do, for vaccines, we do 30,000, 40,000 people. This only had 2,000 people in it. And it wasn't designed, we didn't know when they started the study that halfway through the study, the virus was going to change, become the variant. So this study wasn't designed to say, does the vaccine work against the variant? But what the scientists did is they looked back at the data and they said, halfway through this study, we instead of trying to attack the original virus, this vaccine had to attack the new variant. How well did it do? And what they were concerned about was that it seemed to not protect against what we call that mild disease. Remember, mild, moderate, severe disease. It didn't protect so well against that mild and moderate disease as the vaccine did against the original virus. but they didn't have any cases of severe disease. Remember that other end when people go to hospital, they didn't have cases of severe disease. So they couldn't comment on that. But all they could say is this doesn't seem to work as well against mild to moderate disease. But this was a very, very small study. And in the world of studies, it wasn't even designed to answer that question. So you have to be very careful that you don't say something like this vaccine doesn't work, because that's not the case. This vaccine works well in other countries. We're worried about what we've seen in this very small study, but we have other reasons to think from the laboratory and from that, looking at that immune response, that this vaccine still might work against severe disease. And what we want to do now at the moment, the most important thing, is to protect people against severe disease and going to hospital. So that's what we're really interested in. So nobody is saying this is a bad vaccine, a vaccine that doesn't work, not at all. What we're saying is we don't know at the moment if this vaccine works against the new variant to stop severe disease. So what we're planning to do, and we're in discussion with the minister, with the World Health Organization, is we're going to take some of that 1 million vaccine we've got. We're going to take a lot of it, we hope, and we're going to roll it out, but in a way that allows us to measure whether this vaccine does protect against severe disease. We're going to ask people to volunteer to come and have the vaccine. And these are people who are not the healthcare workers at the front of the queue now to have the other vaccine that we're bringing in. These are people who this year wouldn't otherwise be eligible to have a vaccine. They're not on the list of priority. So ask people to volunteer. And then we're going to monitor whether or not people end up in hospital. And we've got very, very good monitoring systems in this country between collecting hospital data and linking this, once we start to immunize, linking it to people who've had the vaccine. And what we're hoping to see is whether or not the vaccine does protect people from going into hospital. And if you go into hospital, that's severe disease. So that's where we are. And let me stop there, because that's quite a long story, and I'm sure there'll be some questions.
Thank you so much, colleagues.
Thank you very much.
Dr. Fundile Nyati, I think that's the point where we come in as the co-host of the Uhlelo. I must even teach Professor Helen Rees what tina vaccine is umjovo. Then Professor can get to know that we are at the level where we're saying, let's understand and bring down the levels of intelligence and bring it to the level here, to sense knowledge, so that we go through with you. I think at this point, it's profound that I must thank you for considering us and our community radio stations that we have to take part in this high-tech communication. And thank you so much, Councillor Nonreba Mrela, as my co-host. And I think it's only appropriate now that we can even usher in Deputy Vice Chancellor for the Research and Innovation at the University of KwaZulu-Natal, Professor Musa Mashabela. Your opening remarks, please.
Thank you so much. I hope you can hear me clearly. I'm also very grateful to be invited. And from my end, I think I should also thank you, Madam Speaker, for the invitation. I'm very honored, and all the listeners and all the stations that are connected, Dr. Nyati and other partners that are here, much appreciated. And also, I should also thank Professor Rees for those opening remarks and breaking down the science for all of us to understand. I think where I would like to start is on the side of the fact that, what we are seeing in South Africa is something that is very difficult. We went through the first wave last year, and then we came into the second wave, and all of a sudden things just got worse. And on the community side, what we were experiencing is a lot of illness, a lot of death, and also things that are difficult. When you are under lockdown, it's very difficult for you to live a normal life. And, when that happened, and you're faced with this sort of invisible enemy. What we're looking for is a solution. You know, and time and again, it feels like, you know, we're being promised a solution. You know, when we started at the beginning with the first wave, you know, we were told that, okay, let's just go under lockdown and then things will get better. The health system will be strengthened and then we'll be able to cope. But that was not necessarily the case. And even when we got to the second wave, we started to see even our health system struggle and sort of come under a lot of pressure. Mm-hmm. And for me, I think that when things like that happen, we are really looking for a solution. And in many respects, when the news broke that, you know, we've got this new aggressive virus, or shall I say, the one that spreads very quickly, then people were bothered. And actually to see how much infections were taking, how many infections were occurring, how much death was there, also it became confirmation at the community level of the struggles that we're facing with this invisible enemy. And, you know, I remember in December, you know, there was a lot of pressure on government to come up with a vaccine and get the vaccine rollout, you know, happening. And, you know, when we were told that the vaccine is going to come at the end of January, we were all very excited. And when, you know, all of a sudden, people are taking planes to see, you know, to look at the aeroplane flying from India coming to South Africa to see what time it's going to land. And we all watched as the president and the minister welcomed the vaccine. And it carried this sort of hope that it's going to reduce the misery, the trouble that we were facing. And when we raise people's hopes, then, you know, to then get to a point where on Sunday you're told, actually, no, that was a false alarm. That can be quite a shock. And I think I found myself having to field a lot of questions, you know, listening to a lot of people saying, okay, but what does this mean? And what's going to happen? What now? And it was also interesting how people kind of wanted explanations. You know, people focused a lot, for example, on the expiry date, you know, to say, how can government buy something that is expiring, you know? And some people didn't even hear correctly. They thought that it had expired already. The vaccine had expired already. Mm-hmm. So, you know, Dr. Nyati and friends, I understand that these news were very difficult, especially because they had raised our hopes. And right now, I think that we really need to understand. I also quite appreciate that we are having these conversations, because normally we don't have these conversations. You know, you have scientists talking to scientists. Mm-hmm. It's not often that you have scientists talking with our officials, talking with our communities together to try and make sense of something so complex. So for me, I think that the one thing I did appreciate this morning was when the minister spoke to actually reassure, you know, the nation, to say it's not that bad. And I think that's the message really, mm-hmm, that we need to bring, that it must not necessarily make people lose hope. Already people have suffered a lot during the second wave. People have lost loved ones. People are still hurting. And people are angry also, which we fully recognize, because you know, when you're looking for a solution, you want your government to respond, you want to have that answer. And so we are waiting for a solution, and it's not all lost. And I'm sure Professor Rees will also share the results of the other vaccine that looks more promising, that is going to be used for healthcare workers, which she already mentioned. But I should say, Dr. Nyati, that I think that, you know, our communities at this point can ask whatever questions that they have and express whatever emotions, feelings that they have, so that we can, as best as possible, answer the questions that they have. And it may not necessarily solve all of the problems they are faced with, or the struggles that they're faced with every day, or even all of the questions that they have. But otherwise, it can at least start to alleviate some anxiety and put them at ease. Let me pause there. Thank you.
Professor Mashabela, thank you very much for that contribution. I think from the radio point of view, we should be asking certain questions from, common sense and logic, because we are not at the level of you as academics and all that. And thank you so much for mentioning that. You also acknowledge that, we are actually appreciating that we are now scientists talking to scientists. Now we're saying, scientists and doctors are now talking to ordinary men and women on the ground who are the laymen. Now let's just get one thing straight. The panic that we saw, maybe the question should be, what does the announcement by government of halting the rollout of the AstraZeneca, vaccine mean to the nation? Maybe it's the phraseology. And, when we were debating with my colleagues who said, maybe government should go back to spend money on the, the spin doctors, because, the spin doctors would have sounded more local and make us understand before the panic. I think we should go back to those spin doctors to make us understand, because at the end of the day, one says, is it a case of somebody who just spotted this? Because democracy says to us, anybody can just be a whistleblower. Somebody at the airport saw an expiring date or whatever they saw caused the panic because of our democracy is that open. Maybe we should get to that point. Are we actually communicating well? Or as we speak now in Switzerland, they are talking about the very issue of halting, as in not stopping. So can you explain it to the layman's language? Why the panics?
Okay. Maybe that question. Let's ask Prof. Rees. To answer that question in terms of this suspension, what does it mean? But maybe at that same point to say there was a rollout program with 3 phases, and it was going to start with healthcare workers, and the AstraZeneca vaccine was supposed to be the one that's going to be used. So what modifications or what changes have there been now, or are they in the plan? Because we know that the vaccination is coming.
So, I mean, first of all, the suspension, what does it mean? I think that's very fair. And perhaps, what was lost was the small print of what the minister said, which was he's going to pause this rollout. He's going to replace the AstraZeneca vaccine with the J&J vaccine, and I'll come back to that. But he's going to consult with scientists. And I think that bit was lost. It sounded very definitive, very, the gate is closed. That's it. We're not going to roll this out. So believe you me, I've spent more time in consultation on this since Sunday than on anything else I've done. And so that consultation with scientists has been really, really robust. And it's not only within South Africa. I've had 3 major meetings with senior scientists and clinicians in South Africa to hear their views, with international scientists also contributing. But I've also spoken extensively to the World Health Organization in the African region, who I work closely with, and the World Health Organization at the global level. So all of this dialogue, and it's not only me talking, there's several of us who are scratching our heads, and we're meant to coordinate what the scientists are going to advise the minister. And as I say, the conclusion we've come to, and the World Health Organization, by the way, is recommending rolling out this vaccine, even if you have the variant that we have. So what we're saying is, let's push the vaccine out as quickly as possible. Not the kind of very detailed clinical trial that many people have heard of that we did when we were trying to develop the vaccines. But we're going to push it out for volunteers who are willing to have it. And the message is, we want to understand whether or not this vaccine protects against severe disease. We don't know. We don't know. And it might well do it because it's doing well in other places. But it might not because of our variant. And that's what we want to find out. And it'll be for volunteers who wouldn't otherwise be in that first group of healthcare workers who are going to get the vaccine. So it's people who would otherwise probably not get a vaccine this year. And many people might say, well, you know what? If this is likely to give me benefit, but we don't know, and if I can help solve this problem, not only for South Africa, but for the many countries, 32 countries in the world who've now got this variant. And if that will allow a good vaccine, which is an accessible vaccine and a cheap vaccine, to be made really available worldwide, I'm willing to do that. And many people have said to me that they would certainly be willing to volunteer. The one thing we do know about the AstraZeneca vaccine is that it's safe. It's now been rolled out in literally millions of people, and it's safe. So that is very reassuring. So that's very different to saying there's a hard lockdown on vaccines and no rollout. What we're saying is now we are trying to find the way to do this. What we've done in the meantime is, because the first group of people in the country who are going to be prioritized to get the vaccine were the really frontline healthcare workers, the people in the intensive care units, the people in the COVID wards, the people who are doing procedures where they're likely to get a lot of spray from a patient who's got infected with COVID, etc. Those are the first group of healthcare workers that we were going to offer the vaccine to. So what we've done there, while we try and find out more data on the AstraZeneca and try and do that as quickly as possible, but roll this out quickly to people who want it, for that group of healthcare workers, they're going to get a different vaccine called the J&J vaccine. Now, the J&J vaccine, we do have clinical information. So we have information about how good it is about protecting us against our variant. We only have that information for 2 vaccines at the moment. We have a lot of laboratory information, but very little clinical information. So with the J&J vaccines, we know that it is effective against for protecting us against our variant, and again would seem to be more effective against protecting us from severe disease. So that is the vaccine that's going to be offered to those frontline healthcare workers in the first instance, while we at the same time are going to be looking at the AstraZeneca vaccine, rolling it out as quickly as possible and generating some safety data.
Professor Mashabela, your bite on that?
Yeah, so I think from my end, the issue that I want to pick up on is where you left off, is the concern about how we communicate this information. I think the struggle that I have seen throughout the months that we have had of COVID-19 is that what was often considered science that was discussed in scientific corridors, it's now spilled into the public. And in the scientific rooms and corridors, it's okay for us to say that we don't know or we don't understand something. But in the community, we need it's not, people are not going to like it when they ask you a question and you say we don't know. They want certainty, they want an answer, they want clarity. And I find that this uncertainty that comes with the changing science that is happening with COVID-19, be it treatment, be it vaccine, and in this case it's vaccine, makes it very difficult for our communities to know what to do and where to stand. So there's constantly more questions to answer. There's more questions to answer, and this can be exhausting. It's like, when are you going to know? This is what people say to me. You keep saying you don't know. When are you going to know? Do you even know what you're doing? So, and these are fair questions. I do want to say that I think you are onto something when you say that perhaps we need to think carefully around how we package the message. And here, I'm not necessarily talking about spinning in a negative sense. It's more about how to make sure that the message is appropriate for the people that are listening. And indeed, I do believe that, you know, when I was listening to the minister today, the way he was packaging the message was very different to how the message sounded on Sunday. On Sunday, really, it did kind of make us feel panicked. But today, it was a lot more reassuring. So you can call that spinning, but this is still the same minister who's addressing us on the same issue. But now it's almost like there's a lot more clarity. And I understand it may be that because of the consultations that happened, that Professor Rees is talking about, that happened since Sunday up until now, they have provided more clarity. But there is something that I picked up this morning that kind of bothered me, and maybe Professor Rees can also speak to, is this issue of swapping or selling vaccines. Because the minister mentioned that, oh, maybe we will swap the vaccines with another entity, or we will sell the vaccines to another country. But I'm actually much more reassured by what Professor Rees is saying, that we can still roll it out because of the opportunity that it still offers. But if we are going to roll it out, then we need to also explain to our communities how that is of benefit to us, when on Sunday we were saying pretty much that it doesn't work. That's the message that people heard. But we are actually not saying that it doesn't work. We are saying that it doesn't, we don't have the evidence that it's able to work properly against the variant that we have in South Africa, especially in terms of protecting us against a more serious disease that lands us in hospital or in ICU and so forth. But there's still more work to be done. How do we communicate this? How do we make this clear to our communities without confusing them? Mm. This for me is the question, because on the scientific side, we get it. I get what Professor Rees is saying. But now, when I'm thinking about how to translate that to our communities, I still have to say that, you know, we have to do more research. They don't want to hear that. They want clarity on what is the position now. But how do you convey that without actually lying to the people? And how do you say it without necessarily saying to them that you don't know what you're saying? How do you say that confidently with clarity? That for me is something that I would like to hear, how we can translate what Professor Rees is saying and actually make sure that it's clear to our communities.
At this point, I'm going to welcome communities out there. If you want to be part and parcel of this conversation and engagement, we'll be talking to professionals. You can call the number 011-92-4495 or 011-92-1141, so that we can engage with communities, coming to the level of communities, and also to acknowledge in our midst that we are actually having MMC Loiso Masuku, the MMC for Group Corporate Shared Services in the city of Johannesburg, who's on the platform listening to us. So meaning if she feels somehow, you know, bad, she can call in and say, hey, colleagues, we're losing you. We said we're going to bring it to the level of a layman. Maybe the callers will actually redirect us to say, sifuna kanje, sifuna ukuthi Professor Helen Rees at umjovo. Professor Helen Rees, you know umjovo, angithi? Do you know umjovo?
No, you're going to have to explain to me.
No, it's the jab.
With apologies, with terrible apologies.
Umjovo is the jab, you know, like a vaccine. You know,
yes. Got you.
Yeah. Now, we'll be waiting for the listeners to come in, and every time there's a listener, I'll try one way or the other to use some, you know, expertise to make you aware that there's a listener waiting out there to engage with you. But at this point, maybe to the two professors, maybe Professor Rees, the government says scientists will continue to do some research on the AstraZeneca vaccine, on how the country could still utilize it for its population. What does this really mean?
So what we're proposing to do, just bear in mind that this vaccine is effective against the original virus. I'm going to say that again. And it's been widely rolled out in, for example, the United Kingdom. Millions of doses have now been given. And the World Health Organization has just come out with a strong recommendation saying this vaccine should be rolled out, including in countries that has the variant, because that study that has worried us all was a small study, and it showed reduced effect against only mild and moderate disease. But we've got this big question mark. What we want to do is protect against severe disease. So instead of doing another trial like all the trials we've done in the country, excellent studies, very detailed, we're going to do a different sort of study where we're going to ask volunteers to come forward, and then we're going to give the AstraZeneca vaccine, and we're going to see whether or not people end up in hospital. Not because the vaccine causes that, but we want to see how well does the vaccine protect against severe disease that will end up with people going to hospital. And so it's a different kind of study, and it's looking for volunteers that will take it. And we want to do this as quickly as possible. But just to say that, you know, we've also been talking to our colleagues in the region because this variant we've got has spread to many neighboring African countries. And they're very keen to also join us to do a study like this, a very quick study with rolling out the vaccine and looking at whether or not we can stop people going to hospital by using this vaccine. Once we know that, it'll be much easier to then say, right, then we can now roll out this vaccine as we are with every other vaccine that we will get.
Now, the other thing is, I mean, what was really considered in making this vaccine? Because from what we are hearing, I mean, common sense says Europeans, because of their climate, it would be appropriate that they share the knowledge into their space. Because when we come to the continent, it's a different climate altogether. Wasn't it supposed to be the knowledge of the scientists on the ground, coming together, forming a team and say, for the climate, we can then do something to an effect of the climate? Because it looks like that was not considered.
I'm not sure. Okay. No, I'm not sure if the climate actually features here. I remember at the beginning of this whole pandemic, people were talking about the climate, once it is cold or once it is hot, but that theory has gone out of out of the window. So really, I think the climate does not feature. What features though is a number of other variables. I mean, in South Africa we've got people with HIV, and there's pregnant people, there's children, so there's many other variables. And I think Prof. Rees maybe is the right person to just tell us a little bit about that. But I think the climate thing does not feature anyway.
I think I'm now personally giving you the position of a spin doctor in the whole matter. And take it just for this interview, I'll say Dr. Fundile Nyati is our spin doctor, and he always put us back into track. Professor Rees, the climate issue.
No, that's quite right. This virus hasn't even sort of respected hot summers. It's just plowed its way through with first waves and second waves. So the climate is not an issue. Many vaccines that we have are universal. So we use the same vaccines around the world. Sometimes some vaccines might behave a little bit differently in one country in different conditions to others. But by and large, we use the same vaccines around the world, and by and large, they work as well in one place or as they do in another. So that's not an issue. But it's quite right. There are many other questions that we still have to answer. And I know people don't want us to stop doing research, but I'm going to remind everybody about something that many people have lived through. Remember when we started with HIV? We had no drugs to treat it. We had no way to prevent it other than condoms. Now we've come so far with research. The first drugs we had caused lots and lots of side effects. People didn't want to take them. We've now got drugs that are causing minimal side effects, much easier to take. And we're moving on to looking for things that you can take every 3 months or every 6 months. So unfortunately, or fortunately, science is good because it doesn't stand still. It's not satisfied to say, we found a treatment and you have to take a tablet every day. It says, we found a treatment and we can make those treatments better and we can make prevention better. Everyone's lived through that with HIV. Now we're 1 year into COVID. It usually takes about 10 or 11 years to develop a vaccine. And we've got at least 6 vaccines now where we've got evidence about how effective they are and how safe they are, and they're being rolled out. So this is absolutely rapid, fast science. But I understand that what is difficult is what appeared to be a sort of reverse of what was said on Sunday. But as I say, if you listen to what the minister said, he actually said, I'm going to talk to my scientists. But that piece didn't come out and everyone said, the vaccine, oh dear, the vaccine doesn't work and we're not going to roll it out. So I'm trying to correct that understanding with what I'm saying now is that vaccine does work. We think it probably will work against severe disease, but we're not sure. And we need to evaluate that now by rapidly rolling it out to a lot of people who volunteer and seeing if we can actually prevent that severe disease.
Now, Professor Mashabela, you come from the region that is so concerned and overwhelmed by the 5G network connectivity. Is the myth settling now? Are you getting good messaging to the communities? And are you happy with the response now that people understand that it was just a myth?
Colin, you ask very difficult questions. It's so interesting you asked that question because this issue of myths, when we look at it, we just call it a myths, but these are beliefs, that people have. These are things, these are stories, and they represent people's lives and everyday kind of views. And I understand that as someone who would probably not agree with those views, it's easy for me to label them and to dismiss them. But what I have found helpful is to actually engage with those views. I like to kind of sit down. I mean, I had a long conversation with a driver who actually believed that the 5G towers needed to be brought down. I was very interested to understand where he was coming from. So, and we must not dismiss them, even people who were saying that, the vaccine is got technology in it, it's got chips in it that are going to be injected in us. I like to listen to that and understand where people are coming from. And it's been so fascinating kind of listening to that. And you can see how the different understandings start to cross. And when they cross, they can easily cause misunderstanding. So for example, if you look at the vaccine that we are going to get called the Pfizer vaccine, which uses messenger RNA, a lot of times when we talk about it, we talk about the technology that is in the vaccine. It's so advanced. It's very impressive. But actually, in everyday language, when people think of technology, they're thinking of computer technology. And it's very easy for someone, when you are carelessly using that language, for them to understand that in terms of computer language. We are talking here biological and medical technology, but we are not being explicit. And for someone in their mind, what they understand is this sort of computer engineering type of technology. So they will think of chips when you are thinking of mRNA, when you are thinking of DNA or RNA or something that has to do with the biology. So for me, I would like us to actually listen more, not dismiss people, not shut them up. Yes, we may not agree, and I don't agree, of course, but when we listen more, we start to find out a whole lot more other issues that underlie the the views that they hold, and we are able to then unpack them and address them. Some of the people who are upset about the technology, they are very angry about the politics in this country. They're very angry about the state of affairs. People have lost jobs. They're unhappy. They are sad. They have lost loved ones. There's a lot of mistrust. They don't trust government. They don't trust healthcare system. I mean, we try and convince people to say that when you are having symptoms, you need to test, but they don't trust. We want people to come to the clinic. They don't trust. They worry they will catch COVID. They worry if they want to go to hospital, they will die. We want to unpack these things and fix them. And it goes back to the point you were raising earlier. How are we communicating?
Mm-hmm.
And so for me, I would really like to appeal that instead of just kind of dismissing views that people have or beliefs that people hold, to try and listen and walk with them in modifying those views. Because eventually, when you explain, people do understand. It's not that people are incapable of understanding, but we make it difficult for people to understand when we don't take the time to listen to where they're coming from and to be able to explain things in a language that people understand. It's so easy for me to just speak to the science and say, this is what the science says. And when I start talking about science, I just keep rolling. But I forget that I'm speaking to a person who views the world from a certain perspective, and they've got their own way of explaining the things that they're hearing. So let's not forget that when we talk about these technologies that are biological technologies and medical technologies, other people are thinking of electronic and electrical and engineering and computer technologies. That's what they know. So we must just make sure that we accommodate things and we are able to use examples that people can understand.
Dr. Mushabela, I actually see you writing a book already on these issues and addressing the whole matter. But now maybe let's get to Professor Helen Rees, because of the importance of education. It's key, Professor, and how we actually disseminate this information, even to a point that lately now people are saying, why isn't this written in many languages? Because at the end of the day, it's like it's close into the academic space, and academics can do as they please. At the end of the day, we find the lowest person say, "Batin labant, batin abonyati." You know what, badlalamati. Professor Rees, let's come to the education side. How important is it that education should be simplified as a priority?
Completely important. I totally agree with you. And I think we need to, there are such good infographics. There's such clever ways that you can explain how a vaccine works. You don't even need many words, and it would be very easy to translate it. And I do think that after this episode, as we've just heard described, where people heard one thing on Sunday and took away one message, and now we're trying to explain a slightly different message, that has to teach us something, that we have to be extremely careful as scientists, how we communicate, definitely. We have learned that, social media shows you the power of just short clips, a few words. That can be extraordinarily powerful, but we've got a gap in this country between the hard science and where we need to be communicating. So I just say, yeah, absolutely, bring it on. Even a discussion like this is so important, that we can actually open up and try and explain. And I'm trying to do as simply as I can, but try and explain in accessible ways what has happened here and why it's happening.
My good Dr. Nyati, I just want to give you a bite on the side of education.
Well, the reason why I partnered with the city of Joburg from March last year, it's exactly that. There's been a vacuum. A lot is explained at the top, the announcements, but I think there needs to be you know, a way of getting information down at provincial level, even at city level, you know, using, you know, accessible language and stuff. So the reason why we have what we have, it's exactly to fill in that gap. So I can't add more to what Prof has just said.
Professor Rees, let's come back to the issue of you know, now after that pause, you're making use of English in the right way. You don't say stop, you say pause. Government said pause, suspend, you know, and just hold it. Doesn't say stop. Now I just want to bring in something here. Us moving to Pfizer and Johnson & Johnson. Here comes a cheap politician on the ground, says, hey, we thought as much. They'll take for granted the India vaccine and bring us others. And now we have to now say, wow, these are good. Tell us exactly that movement from one post to another so quick. What causes that? And if there's trials, where were those trials done? Because this is a disaster environment.
Well, let me start with that last question. Where were the trials done? South Africa has actually been one of the most active countries in doing those early trials. So the Pfizer vaccine you mentioned, AstraZeneca, Novavax, J&J, and there are others that will be coming through. But we've been a very active research community, and I think we can be very proud of that. So we've really contributed a lot of not only sort of science, but also of our citizens' time and voluntary effort by participating in those trials. So that's very good. Now you're saying how did it happen that we managed to, you know, we jumped from one to the other? Well, I think that you know, the country now, and I think this is fantastic. Actually, really, I think most people in the country really do want vaccines, and people are saying, when are we getting them? Give us these vaccines as fast as you can. And the minister had made a promise. He wants to keep that promise to start to roll out in February. And so he was able to go to one of the manufacturers, Johnson & Johnson, because they had already been talking to the government about selling vaccines to us, and because we had done a large trial for Johnson & Johnson in South Africa, there was already an existing relationship. So the minister and the department were able to go to that manufacturer and say, can you urgently fill this gap? We need to wait now to get more data on AstraZeneca, and we'll do that as the way I've just explained. But can you fill that gap? And that's why we got the J&J. But worldwide, I think everyone must understand that there's limited vaccine this year, and we're competing with everyone else who wants vaccines. The African Union is trying to buy vaccines for many African countries, ourselves included. And there's another big initiative out there called COVAX, which is also trying to buy vaccines so that they can ensure that it's not only the rich countries that get the vaccines, which is what we're seeing at the moment, but actually the middle income countries like South Africa and the poorest countries. So there are a lot of efforts to try and get vaccine. But I think what everyone must understand is there's not lots of vaccines sitting on the shelves that South Africa isn't going to try and buy. We are trying to buy that vaccine.
Now, maybe the issue of certain good things are lost in translation. Maybe let me be the president for this point, and my deputy is my wonderful Dr. Fundile Nyati. You are my deputy. We are at the airport, and we're making this announcement. Ladies and gentlemen, fellow South Africans, we are now receiving the vaccine. And this vaccine will be handed over to the scientist for, you know, to peruse and check all these little things, you know, and don't talk about rollout, you know, and say in the midst of us actually receiving this, there is Johnson & Johnson and Pfizer that our scientists have been working on and have a beautiful knowledge of it. We'll start rolling out that, then we'll wait for the feedback for the scientists who are receiving now the vaccine that everybody was happy to see at the airport. Are we losing things in just beautiful translation, or we just an excited democracy that just go for things and we becoming crisis managers? My deputy?
Well, I think I think what you've just done, is to just highlight the need for effective communication. I think it's a challenge. We need to improve. When I say we as the country, the ministry and the various levels, there needs to be improved comms, and that way we will mitigate some of the issues that we are now facing. Have to correct things that should have been clear from the beginning. But it is fine. It's a learning, for all of us. So I think what maybe we also need to do is that also as the public, now non-medical, non-scientist, we also though need to acknowledge a few things, that whilst there is democracy of information, we're getting information from all sources, but the interrogation and understanding of information does need certain skills. It seems like everybody is an expert. I am worried about that as well. Whilst we are saying let's tone down the message, but I think people must also know that certain information, you need certain skills to have to be able to understand. And those who have those skills must then learn to communicate. So, but I think that is fine. So yes, the communication could have been better. And maybe the lessons have been learned, because the minister this morning, his message was very, very clear compared to the message on Sunday. Same thing, but different way of saying it. So I agree with you.
You're doing so well in that portfolio, Dr. Nyati. I like you. Now, for the sake of radio, that's all the time that we had. But I want to leave you with this as academics. The pandemic and the lockdown has had an impact on people's mental health. I just want to find out how severe will that be. I know I'll get a transcript of how you answered, but I'm going out and I'm letting now my partner in crime, Councillor Nomneba Mulwele, to take over from here, as radio will pause from it's halting. Radio is halting at this point. Thank you so much. Thank you so much, colleagues.
All right, thank you.
Thank you so much. Thank you so much, Colin. And thank you to the Josie FM listeners and all the listeners. I will hand over to you. Are co-chairing with Dr. Nyati. So okay. Doc will take over, and also so that we can hear what our viewers are saying.
Yes, I think we've spent a lot of time around what happened on Sunday and the implications. But I think we also need to hear more around, this. Now we are going to use J&J, vaccine, which has been tested here, and maybe that message needs to come through. So I think Prof. Rees will have to just come in there, a little bit of, these are the tests that were done, these were the results, and when it comes to severe illness, this is how this thing was found to be, effective. Results came out about 2 weeks ago, or 2 or 3 weeks ago, around that. So I think that, but there are some questions that have come through SIPO. Maybe you can just take quickly.
Josie FM, your source to entertainment, education, and information.
Josie FM must now mute. All right.
Thank you very much, Doc. Thank you very much to everybody, and very interesting discussions indeed. We have some comments from people on social media. Indeed, people are concerned about where we are as a country. And the first question that came earlier on came from Elias Ntsimini. And I think Professor Helen may have responded to it, but he goes on to say, did we as a country do a proper research on this particular vaccine? So that's the first one. The second one comes from Tintswalo Elizabeth Maluleke, who says, City of Johannesburg Speaker Office, Madam Councillor Nongeba Mulwele, great work you are doing for enhancing engagement with COJ citizens in the consultation of clarifying the vaccine benefits to our immune system. Elias goes on to says, what I heard is that we bought the vaccine that still needs to be tested. For instance, compare this vaccine with other vaccines from other countries to get a proper and effective. Also, the one that can stay longer on the shelves? I think, Prof, maybe you have responded to it, but maybe if you can go back to that. We've got another one here, says, I also heard J&J and AZ vaccine. Which one is effective? And why is the viral growing so fast here in South Africa than any other country in Africa? So I think I'll pause there for now. Thank you very much. Maybe before that, let me also acknowledge, Madam Speaker, to welcome Councillor Matshidiso Mfikwe, who's here, and also acknowledge, I know that she was acknowledged earlier on, MMC Masuku, who's also here, and all the other people that have joined us. Thank you very much.
Okay, I think maybe there's a question, Prof. Rees, around just these two vaccines, because I think we're talking AstraZeneca, but we're also talking, J&J, and maybe briefly, South Africa, has been involved in both vaccines in terms of the research before they were actually, announced. Maybe to reassure people around that, so that they don't think we are only researching them now that they have come into the country. South Africa has been busy in that space.
And has there been proper research done on the vaccines? Yes, on all these vaccines, proper research has been done, absolutely. Remember what's happened here, the changes that we got the variant. And as the virus changed, what it did was it changed the parts of the virus that were being targeted by the vaccines. It just changed them. And that meant that for many of the vaccines, there are a bit less or more so, less effective against the variant, but not completely ineffective, not at all. So the first question is, was the research done properly? Yes. The second point I would make, I chair the board of the South African Health Products Regulatory Authority. That's our drug regulatory authority. Yes. We won't let a vaccine in unless the research has been done properly and we're satisfied about the safety and the quality and the ability, the efficacy, its effectiveness in preventing COVID. We won't let that in. So you can be assured of that. And just bear in mind that the problem we've got is the variant, and it's a problem for every country that's got the variant. And this variant is aggressive, and that's why we saw this wave. In terms of why is South Africa more affected? Well, in fact, we're seeing these second waves in many countries now in the African region. And like South Africa, they are much, much worse in many countries than the first wave. Many countries indeed didn't have such a steep wave in the first time as we did. But now we're seeing that many countries are having a very, very steep second wave. This variant is really taking hold. But the other thing that we know is that many countries who during the first wave hadn't established such good mechanisms to pick up infection have now developed much better systems to pick up infections. So what we're also seeing is the benefit of our neighboring countries also improving what we call surveillance. That's the ability to screen people and pick up COVID infections. So that's what we're seeing. And although you're right, South Africa at the moment has got on record the highest numbers of deaths, we are unfortunately seeing that other countries are now also grappling with this very, very big second wave.
Yeah. All right. Maybe let me just ask Prof. Mushabela. Right. Since South Africa announced, I think sometime in December, the new variant, even at that point, it was clear that we're saying this is not a South Africa. There was this China virus and whatever. So the minister was saying, this is not a South Africa virus, but we have heard countries outside of South Africa and maybe, especially in the developed world, continuing to talk about the South African variant, and other people are uncomfortable about the stigma that comes with that, you know, in the same way that there was stigma around China virus. So I just want your comment there. Is it fair for South Africa, you know, that people are now almost like we are these people who are breeding this virus that is very, very dangerous, that, you know, we must not even be allowed in their countries? I don't know, I'm just asking from a lay person now. I've put my medical thing on the side.
No, it's a fair question. And I think that in a way, in South Africa, we are victims of our own success, you know, because we do so many things and we get many of them right. We can pay a price for it. And I'll use a few examples in terms of that, Nyati. One is that South Africa positioned itself very early on to do these tests to look at mutations at how viruses change over time, very early on, a very powerful network. And they were quite open about it, and they announced it publicly, and they didn't know what they were going to find at the time, but they knew they had to do the work. So now, when you now pick up a variant because of that, then you can easily be stigmatized. But that is the success of what you have put in place, the systems you have put in place. Because then that variant could have just circulated without us knowing about it. And in many places, it was circulating without people knowing about it. Then you become a victim of your own success, which is why even when the UK was being harsh on South Africa, the South African scientists were saying, but you're being too harsh on us. And you're making us pay for actually picking this up, which is supposed to be a good thing. And it relates to another example in terms of one of the questions that Sipho just mentioned about when the vaccine arrived, it was then put away to be tested, right? And he's saying, what I heard was that this vaccine still needed to be tested. And to the person listening, it's like, why are you buying a vaccine that you still need to test? So, and here, what we are trying to do is the due diligence of quality checks. When the regulatory body takes these products and they do, in the same way that the South African Bureau of Standards would check things and make sure that the quality is good before they put a stamp on it. You do that. But now, to a person listening to the message, to them what they hear is, you're still going to test it. So why are you buying something that you said you're going to? And here you're paying for your due diligence of making sure that you're doing quality check. But people think that you're still testing the virus, whether it works or not. This is where the confusion comes. And then when the results come from a different clinical trial, people think that this is the results of that checking that they were doing. And those two things are not related.
Thank you.
But again, the results of the trial, again, they're important. That's also where we become victims of our own success again, because we know that we could have let these other countries do clinical trials without us doing any trials in South Africa, even the AstraZeneca vaccine. And if we had not done the AstraZeneca vaccine trial or any of the trials in South Africa, we were going to, like everyone else, be quick to say that we want the AstraZeneca vaccine because it's easy to store for us, it is cheap, we understand the technology on the virus, it's accessible. We would have said that we want it and it would have arrived and we would have just rolled it out under the assumption that it has 70% efficacy. And if we had not done the genomic studies where we were monitoring the mutations of the viruses, then we would not have known that either. So we would have just carried on, right? So, but now because we have done the study here and we are able to see the difference in the results from the study that we are doing here in South Africa, and the results of a study that we are doing in the UK or elsewhere, and we are able to deal with those small differences, then we become victims again of our own success, because it is success to be able to show those results. But now it's coming out and it's like a bad thing. We should be saying, oh goodness, thank goodness we found out, because we could have missed it. That's what we should be saying. We should be saying, thank goodness we found out. And again, for having done the Johnson & Johnson trial, at the same time, we are able to see that, of course, because of our variant, it doesn't work as well as it does elsewhere where they don't have the same variant that does. But actually, it offers really good protection, especially against serious disease or death. If we can get 9 in 10 people protected from severe disease, serious disease and death, that's really good. And immediately it offers us an alternative. We are manufacturing it in South Africa. We are doing the trial in South Africa. We can negotiate. We have the leverage to negotiate with the company. If we were not doing those things, we would not even have the relationship with that company. This is why I'm saying that there is this sort of repeated message of us really shooting ourselves in the foot for actually doing what is good. So I think that in a way we have to just remember that, you know, all of these things that are throwing the spanner in the works, as people say, or the curveballs, they are actually coming out because of the good work that South Africa is doing on the ground.
Okay.
Let me pause there.
Yeah. Maybe let me just ask Prof. Rees. She mentioned that you know, we will be looking at J&J vaccine and many others. And also the minister in the morning did mention that, you know, they are going to consider the one from Russia, Sputnik, and then they will also be considering Sinopharm. Maybe can she just help us a little bit around that?
Yes, so as I say, it's very important as these vaccines are shown to be effective